Hello everyone. So I'm talking on integrating clearance mapping with MapRT into clinical practice. So I guess I'll first introduce myself. So I'm one of the Deputy Charge Radiation Therapists at Peter Mac Moorabbin. So Peter Mac is comprised of 5 distinct sites or different campuses, and the Moorabbin campus is Peter Mac's second largest site, and we're located in the southeastern suburbs of Melbourne. So we have 2 LINACs, 2 of which have a line RT capability, 2 dedicated CT scanners, and now also MapRT. So I won't go too much into detail about what MapRT is, because we've just heard about that from Dave, but just briefly, MapRT is a clearance mapping program that enables a full clearance assessment of a patient's position and their proposed plan prior to the patient coming in for treatment on fraction 1. So a full body surface capture can be taken of each patient during their CT appointment, which is then available later for planners to use within the MapRT clearance program to then assess their plan geometry. So the MapRT system at Moorabbin consists of 2 ceiling mounted cameras and 2 dedicated MapRT computers. So one inside the CT room and one outside in the console room, so they're mirrored. So after the CT capture, the planners are then able to export their proposed treatment plans directly from the treatment planning system into the MapRT program. So the clearance program is a web browser based one, so our planners can log in from their own computers, which is great. And the interface is also very interactive, as it shows you the patient's position, isocenter coordinates, imaging arms, couch positions, basically anything you need to do a clearance assessment. And also all of these aspects can be adjusted in the program of the clearance map, and it will update itself as you're changing it. So MapRT was installed at Moorabbin following the installation of our new Siemens CT scanner on the 20th of May last year. So our lovely physics team then spent the next few weeks validating the accuracy of MapRT using the above pool noodle phantom to mimic patient geometry. So the phantom was evaluated by measuring the trigger points of both the machine and patient interlocks, which was then compared back to MapRT's software clearance map. So overall, our physics team found that most measured collisions agreed with MapRT within 1 degree, so that's great. However, because MapRT software isn't officially released for clinical use yet by Vision RT, and Peter Mac Moorabbin is one of the beta testing sites for the program, we are still encouraging our staff to perform a mock-up procedure if they are concerned at all about a clearance. However, these initial results are very promising. So following MapRT's installation, we undertook a one-day vendor training session involving our CT staff, our education team, and our clinical leads. And the subsequent rollout of the MapRT training to the rest of the planning staff involved making decisions as a group on how the new procedure would then integrate into our current workflow. So a competency checklist was then created for the trainers to follow when delivering training, and also keep a record of which staff had then received the training as well. So over the course of a week, each morning the CT was booked out for about an hour, and a different planning pod would then undertake the training. And in terms of ongoing staff training from there, any new staff that rotated into planning from treatment were upskilled either by the educators or by their fellow planners as required. And once all the planning staff were trained, we then assessed how the RTs were utilising MapRT and what we found it most useful for as a department. So in terms of the workflow for MapRT, the first part of the process is conducted at CT. So once the patient's set up and on the bed, you input the patient data, so just some basic information like the patient's name and ID number. You then take your first capture. That capture needs to be taken at your treatment reference point or your subsequent 0 slice. You then need to assess the quality of that capture, so make sure there's no sort of gaps in it or any missing information or equipment. If you do need to, you can then move the bed away from the gantry to take a second capture, and the program will then automatically merge those together. The last part of the process is inputting the DICOM couch height from the CT, and it's just really important to note you can't change the height of the couch between either of the captures or the scan itself. So it's a pretty quick process, and that capture can be taken either immediately before or just after the CT scan. And it was suggested to us to take the capture prior to scanning during our vendor training. And that's because the surface capture can then be reopened in the MapRT browser to assess potential isocenter placement and gantry clearance whilst in the CT room itself, to then allow for any adjustments to the patient's position prior to scanning. So once the capture and the CT have been completed, the next part of the workflow actually occurs during the planning phase, where plans can then be sent directly from your treatment planning system into the MapRT program for the clearance assessment. So as mentioned before, MapRT is a web browser-based program, so our planners can log in and access the program from their own computers, and we've found that there's been no restrictions with its use. So we haven't had any issues with, too many people logged in at once or anything like that, which is good. So in terms of integrating MapRT into our own workflow, we decided to take a MapRT capture of all patients who had a CT scan with us to try and build up a bank of patient data, which we can then use to assess utilisation and also for any future projects. We also found that the MapRT capture was easiest for staff to actually take after the CT scan procedure itself rather than before. And although the MapRT capture process is relatively easy, the capture is still adding an additional step to the overall CT process. So it does add about 2 to 3 minutes of additional time that the patient must remain still in the overall appointment, which for some patients obviously isn't an issue, but for others might be problematic just depending on their performance status. So taking a MapRT capture of all patients might not always be possible. So in addition, MapRT also needs to be QA'd every morning prior to its use. So this does add an additional 5 minutes or so to the CT's morning QA time. So following staff training and the integration of MapRT and its capture process into our CT workflow, we then found a couple of clinical learnings from this. So firstly, we found that any stabilisation equipment that had a dark or a shiny surface was actually not captured by the MapRT cameras and would leave sort of dark holes in the picture itself. So this is a known issue. These cameras are the same ones as the Align RT cameras. And to work around this issue, we just ensured that all equipment was either covered by a sheet or something non-reflective, and then reviewed the captures really thoroughly to make sure that all relevant information is included. Secondly, we found that as with any new process, remembering to perform the capture before then just automatically going into the CT room and getting the patient down and off the bed was a little problematic at the start. So to help prompt our staff to remember the new process, we actually updated our CT document with a MapRT section to fill out. And we found that this really helped with the uptake of our MapRT captures being taken. So interestingly, we actually also found that the MapRT captures can be taken retrospectively for any patients that have personalised equipment, so patients such as your head and neck. We were then able to use their equipment and the CT DICOM coordinates to actually take a useful capture retrospectively. And lastly, ensuring the patient is actually exposed for the capture and not covered with a sheet or anything else that might interfere with the MapRT and not give us a true surface capture. So we also ideally need to ensure that any equipment that's not relevant to the patient's position is also out of the way. So things such as bulky blankets or hover mats, which if they are included in the surface capture, might produce a false collision warning down the track. So after a couple of months of using MapRT, we then assessed how our planners were using the program, and this gave us a really great insight into its usefulness within our radiotherapy department. So overall, we found that MapRT was extremely useful for helping our planners select optimal beam angles, visualise any non-coplanar plan geometry, and also assess imaging clearance. So we found that assessing appropriate or achievable beam angles was one of the most helpful features of MapRT. So since its integration into our department, we've seen a really large uptake in its use with our breast planning. So knowing that elbow clearance is an ongoing struggle with our breast planning, our planners now routinely send all of their breast plans to MapRT to assess beam angle clearance. So in this clinical example, we have a right-sided chest wall and nodes patient who was planned with VMAT, and at this time we had only recently started using MapRT, so her treatment was actually planned, QA'd and approved before it was then sent to MapRT for assessment, or clearance assessment. So we can see here that MapRT clearly demonstrates that the medial arcs are causing a collision with the contralateral elbow. Now, if MapRT had been used earlier in this planning process, the arc length could have been adjusted to allow for that elbow position. However, considering the collision was only caused by the contralateral elbow, this plan was still used for the patient's treatment, but the planning staff were actually able to then use this information to flag the potential collision to the treating staff in the setup instructions. So it was still useful. So I'd say the second most effective application of MapRT is in planning scenarios that involve non-coplanar angles. So MapRT provides a really great visualization of plan geometry, which in turn has given our planners a lot more confidence with using non-coplanar angles. As previously as a department, we were often quite conservative with using any 4 angles in our plans. So we've seen a really large uptake in the use of MapRT, in particular with our metastatic skin patients. So any electron patient where an applicator clearance might become an issue, or lesions that are located in tricky places like extremities, we've found MapRT to be really useful for. So in this clinical example, we have an electron skin patient with a very superior scalp volume, and this patient was planned in a personalised neck shape and mask for stabilisation. And the planner initially planned this electron 100 centimetres to skin, couch 270 and a gantry 270 field. However, prior to sending this plan off for QA and then doctor approval, the planner actually was able to do a quick plan clearance check using MapRT, and we can clearly see that the plan did not clear at these angles with the electron applicator. So MapRT was able to demonstrate to the planner that the electron applicator would have collided with the patient's neck shape and potentially caused setup issues on fraction 1 of treatment, and potentially by the end needing a replan and even causing treatment delays as a result of it. But because we did use MapRT during the planning process, the planner was then able to account for this clearance issue by just making a 10-degree adjustment to the plan. So still dosimetrically acceptable, and MapRT demonstrated that this was much safer for clearance overall. And just another example of MapRT being helpful for non-coplanar planning is actually with extremities. So in this clinical example, we had a metastatic skin patient with a foot lesion that the doctor had requested to treat with 3D tangents in order to spare a lymphatic strip along the top of the foot. So this sounds easy in theory, but in practice became a lot more geographically complex, considering the treatment volume actually wrapped around the sole of the foot, which means that we'd need to incorporate couch kicks into the plan and also consider any potential collisions with her contralateral leg, just considering how she was set up at CT. So MapRT became a really vital tool for planning this patient, as we were able to sit with the doctor and visually demonstrate what angles will work for treatment and what won't. So often with tricky volume locations like this, visualising the plan geometry is the hardest part. So yes, you can perform a mock-up procedure in an attempt to check clearance and that the overall plan makes sense, but without the patient on the bed, you're still guessing as to where that contralateral leg will lie. So this was a really great example of a complex patient that became a lot easier and more streamlined because of MapRT's involvement with it. So checking imaging clearance is another really great way to use MapRT. So although imaging fields are not modelled specifically by the MapRT program, you're still able to manually move the gantry to the imaging positions to see if any collisions might arise, and you can alternatively still create dummy fields to export and explore. So in particular, we've been able to use MapRT to assess cone beam clearance to help determine whether the couch needs to be centred to reduce the need for dry runs on fraction 1. We've also looked at KV imaging clearance for patients who are offset on the bed or who have very lateral isocenters, which helps us to predetermine if the imaging panel vert needs to be extended and also to select potentially some more appropriate imaging angles for that patient, like obliques. So in this particular example, a pelvis patient was planned feet to gantry with a very lateral isocenter and initially planned with imaging angles that were standard KV0 and KV90, which on fraction 1, unfortunately didn't clear with a panel vert of 50 and needed to be extended to 60 for clearance. So after fraction 1 and further consultation from the treating RTs, they actually requested oblique imaging anyway to improve visibility on this patient. The planning staff then created some oblique KVs for fraction 2 onwards, but unfortunately again, one of those obliques didn't clear. So this patient was a really perfect example of how MapRT would have been useful here to check imaging clearance and then select appropriate imaging angles prior to fraction 1 of treatment and therefore reduce that double handling that we experienced. So in terms of future projects with MapRT, we're really interested in looking into non-coplanar planning for bilateral head and neck patients to potentially remove any shoulder positioning issues that can arise from them. We're interested in incorporating non-coplanar geometry into our SABRE planning and assessing the potential dosimetric benefits of this. We're also looking into using MapRT to assess our bilateral breast isocenter placement for clearance, and also using MapRT to model breast cone beam clearance to allow for spotlight cone beams whilst on treatment. So in summary, we've found MapRT to be a really fast and easy interface to use. So sending plans to MapRT is pretty much almost instant, and it provides a really great visual of your plan geometry. It also accurately models that plan geometry, therefore reducing the need for any replans and potential repeat QA work and ultimately wasted resources in the department. It's also given our planners a lot more confidence with non-coplanar planning, as we're able to preempt any potential collisions before the patient's actually in the room and on the treatment couch. And we do acknowledge that the capture process does add an additional step to the overall CT procedure, but we believe that the benefits of actually using MapRT outweigh this. And lastly, I'd just like to say thank you to everyone that's been involved with implementing MapRT at Moorabbin, and also just a really big thank you to the Peter Mac Moorabbin department as a whole, just for their enthusiasm and uptake of the tech. Cool, thank you.